knee flexion and extension. Our landmarks are the lateral epicondyle of the femur, the midline of the femur, and our movable arm, distal arm, is going to be the midline of the fibula. We can also use the malleoli to point in terms of giving us a direction. So our goniometer is going to be out in this position, and we're going to ask the patient to flex the knee, so slide your heel towards your bottom. And I'm going to do my alignment in this position. Make sure that I'm aligned properly. Take my reading, which is 133. I'm going to passively move her and reassess here. Looks like we're at 140. And then I'm going to take my infeel. And again, my infeel in this particular case may be soft, mainly because of my soft tissue approximation in terms of with the knee flexion in this particular case. So typically it's going to be more of a soft infeel because of that calf in the thigh soft tissue approximation. Now, normal ranges of motion for the knee, you're going to see a very wide difference in them. We're going to be using 125 degrees. I've seen as much as 150 degrees. I've seen as little as 110 degrees. And a lot of it depends on your body habitus of your patient. If you have a very thin patient with very small or little muscle tone, you may get 150 degrees of flexion. If you have a very large patient with a lot of excessive soft tissue, you may get 110 degrees. So 125 is typically, you want to see that at least for normal, but it may vary depending on your patient. So this is why you always want to make sure that you do the uninvolved side. For knee extension, when you're checking for recurvatum or hyperextension of the knee, or just in general with extension, you may want to try putting a towel underneath the heel so that you can raise the knee up a little bit off. This also takes away the approximation of that calf that's hitting there, because if someone has excessively large calves, they may have that soft tissue that is then limiting your full extension. Our landmarks are the same: lateral epicondyle, midline of the femur, and the midline of the fibula. And we're going to take this measurement here. Passively, you can push down a little bit on the upper knee here. And then for your end feel, again, I'm off to the side here. I would be much closer to the patient and pushing directly down. And now my movement arm is more my proximal one. This is my stationary arm. And I'm going to push down into that. This should be more of a very firm to bony type end feel. You are going to get a little bit of a springy end feel with knee extension. It won't be as firm as elbow extension, but it should be a little bit firmer than most of your end feels. One of the other things that you're looking for in this position is someone who's got hyperextension or recurvatum of the knee. And a simple test for this is in this position. If you just grab a hold of their toes and lift up, and you can see that I can raise the heel pretty significantly off of the table here. So this is a person that has hyperextension or too much motion, recurvatum of the knee. So if I really wanted to measure that, in this particular case, I probably need a little bit higher here. So in setting again with the towels or pillows or something underneath here, and then you would ask the patient to contract the quad and push the knee down into the table as hard as they can. You can also ask them to do that in this position, and you can see how that raises the foot off here. And I would use the same landmarks and go ahead and take my reading and actually measure this excessive extension. So genu recurvatum or hyperextension. And this may be important especially with ACL injuries. You see that significantly more in females than males, especially people playing soccer, volleyball, basketball. And a lot of reason for this is because females have a tendency to have that more flexibility, and you see that genu recurvatum a lot more, and so what they're doing is they're locking out the knee and they're relying on their ligaments to hold and help stabilize rather than using their muscles. So this may be something important to measure. One of the things to keep in mind though, a lot of times, especially after total knee replacements, you may not get that full hyperextension back. The same thing with after an ACL reconstruction. Sometimes the patient will say, well, I want it to match my other leg, but you don't necessarily want that hyperextension back because that puts the ligament on stretch and puts them at risk for additional injury.